Good morning. I now convene this morning's hearing entitled "Where Have All the Patients Gone?" Examining the Psychiatric Bed Shortage. Dr. Hirshon, you're recognized for 5 minutes.
In emergency departments throughout the country, we emergency physicians expect the unexpected. This is what we're trained to do. Even so, there's one thing that we all know is happening: increasing demand by patients in need of acute psychiatric care. Mr. Chairman and members of the subcommittee, thank you for this opportunity to testify today on behalf of the American College of Emergency Physicians. ACEP is the largest specialty organization in emergency medicine, with more than 32,000 members in all 50 states and the District of Columbia. My purpose today is to help you understand that we're in the midst of a national crisis, facing a dramatic increase in vulnerable mental health patients seeking emergent and urgent care. America's mental health services are experiencing increased demand while concurrently receiving decreased funding, which drives psychiatric patients to the ED or emergency department. In 2000, psychiatric patients to the ED accounted for only 5.4% of all ED visits, but by 2007, that number had risen to 12.5%, well over a doubling of the number of psychiatric patients. Until more services and fundings are made available to address this crisis, EDs will be the safety net for these patients. This is due in large part to the Federal Emergency Medicine Treatment and Labor Act, EMTALA, which mandates medical screening, evaluation, and stabilization for anyone seeking care in an ED. Additionally, unlike many other health care settings, EDs are open 24 hours a day, 7 days a week, every day of the year. Emergency physicians do their best to provide care to patients with psychiatric conditions, but the ED is not the ideal location for these services. ED crowding leads to delays in care and have been associated with poor clinical outcomes. For patients with mental health and/or substance abuse problems, prolonged ED stays are associated with increased risk of worsening symptoms. Without available appropriate inpatient resources for admitted patients, these patients wait or are boarded in the ED until an inpatient bed becomes available or an accepting facility can be found. When the normal capacity of the ED is overwhelmed with boarded patients, there remains absolutely no room for surge capacity, which would be critical in the event of a man-made or natural disaster. In a recent ACEP survey, 99% of emergency physicians reported admitting psychiatric patients daily, while 80% said that they were boarding psychiatric patients in their EDs. Acutely ill psychiatric patients require more physician, more nurse, and more hospital resources. ED staff spends more than 3 times as long looking for a psychiatric bed as they would for a non-psychiatric patient. Other factors contribute to the extended ED boarding times for psychiatric patients, including defensive medicine or threat of legal action, required pre-authorization for inpatient services, medical clearance prior to psychiatric evaluation, substance abuse-related issues, and inadequate outpatient services. As can be seen, many of these issues are systems issues and beyond the control of the clinician. It is imperative that access to high-quality inpatient and community mental health care be a priority. I go into further detail on suggested solutions in my written testimony, but some important ones include full capacity protocols to improve the movement of admitted patients to inpatient floors, separate psychiatric, ED, and behavioral health annexes to help address urgent and emergent psychiatric needs, regionalized care and telemedicine to help efficiently and effectively address increasing demand, as well as the elimination of out-of-network insurance issues and community state mental health buy-in. Let me leave you with this. The increasing burden of mental illness in this country, combined with the lack of resources to care for these individuals, is a national crisis. Mass deinstitutionalization of mental health patients over the past few decades did not result in successful community integration of individuals needing psychiatric services, in part because the necessary services and funding were not put in place for adequate community support. Systematic changes are needed in the way we care for these individuals with mental illness in this country. How we deal with these vulnerable individuals is an important measure of who we are as a society. Necessary resources must be made available for additional inpatient and outpatient treatment beds with the corresponding professional staff, as well as for critically needed research. Otherwise, mental health services will continue to deteriorate, and these individuals, often our family members, will continue to be at risk for abuse and neglect, seeking care in EDs for lack of any other support. I thank you for your attention to this alarming problem.
Thank you, Dr.